Okay, let's move on to figuring out what to do when someone relapses. First, we got to figure out who's at high risk for this. What are there things that we can use clinically to determine risk of relapse? And then I guess what constitutes a high risk patient after they've relapsed?
Right. So as we talked a little bit a moment ago, these are the same patients we think about for potentially putting on maintenance therapy. Patients who still have a positive PET scan at the end of therapy, partial remission patients. There's emerging data regarding MRD. We don't know what to do with it. We also use the Flippy score a little bit to predict. There was some data presented at the last ASH meeting by Carla Casulo and colleagues, so-called FLASH study, where they took data from a variety of clinical trials and used that to predict the 24-month progression of disease. And they found some additional factors in addition to the Flippy score. Unfortunately, it was bad to be male. If you had a poor performance status, that was also, not surprisingly, a risk factor for early progression, as well as an elevated beta-2 microglobulin. I think the challenge with all of these things is that it doesn't necessarily tell us what to do next. It makes us worry a little more. Maybe we may scan someone a little more frequently, bring them in a little more often to the clinic, but it doesn't really guide our therapy. Regarding what is considered early, that same group, Casulo and colleagues, defined this progression of a disease at 24 months as appeared to be a cut point in terms of folks who have a better outcome if you don't have early progression versus those that have an early outcome. Fortunately, 80% of the people did not relapse within 24 months. So the vast majority of patients, and I really like to tell my patients this because I think it's pretty exciting to say that 80% chance you're going to do well. And 20% we need to get a little more serious about treating your lymphoma.
It's a really dramatic difference. I mean, those curves are very wide. I mean, it's impressive that such a simple thing as when you relapsed after frontline therapy is going to predict such a powerful predictor of survival. So there's this data with using natural killer cells at baseline. I mean, I think it's interesting, but about people with lower natural killer cell numbers and function are not going to do as well. But I personally haven't used that. Is that something you're doing, or you think we should be doing?
I think that's really a research setting. It was noted in the Gallium trial as well as the Goya trial that there was some correlation with low NK cells at baseline. And I guess the hypothesis there, when you have a ADCC optimized antibody like obinutuzumab, maybe that makes a difference. But I think it's really a research question at this point.
And we've seen that therapy probably matters with regards to some of these biomarkers. There's been a lot of work looking at level of tumor-infiltrating macrophages and NK cells and T cells. And interestingly, that the ability to predict outcome often depends on the treatment they received prior to getting that biopsy. So it's hard to know with these NK cell levels mean anything if you use something other than obinutuzumab. So I mean, I agree with Jay that it's still a research question. It'd be nice to see if these markers hold true across different types of treatment.
Yeah, that's a really important point. Okay, Scott. Now, the patient's relapsed. You maybe symptomatic or not symptomatic. What's driving your treatment decisions? Is it the same as when the frontline therapy? Are you waiting till you watch and waiting? Are you diving right in? And then how does what matters? What factors into what therapy you decide at that point?
Yeah, that's a great question. So, in terms of timing of progression to treatment, it's very broad, right? So, on clinical trials, they might be doing more frequent scanning than I would typically do in routine clinical practice. And you can note that for, say, gallium, the PFS is very different from the time to next treatment. So some patients may actually do very well for months, if not years, between an actual progression event based on CT criteria and clinical progression. And so for me, time to next treatment is actually a nice thing to see in clinical trials. It gives an idea of what patients, that's an important measure for quality and what patients are really desiring. When patients symptomatically progress, that's when we select a second line therapy. And it's really, what did you get in the first line setting? How long ago did you get it? And how are you doing at this moment in terms of other comorbidities, other factors in their life. And so typically if patients have a nice long duration of remission from immunochemotherapy in the frontline setting, I'm often giving another round of therapy in the second line. And in that situation, usually using rituximab first line, perhaps obinutuzumab chemo backbone on relapse. If patients do not have many years of remission following frontline therapy, then I typically am using a more novel agent. Clinical trials are incredibly important for those patients. We have the intergroup study looking for early progressors, those patients progressing within 2 years of frontline therapy. And so those are the patients that we really need to work hard on to improve the outcomes of follicular lymphoma, because 80%, they're going to be doing well. It's really that 20%, whether it's primary progressive follicular or oftentimes a transformation event that's occurring in those patients.
So Nathan, I think I remember having a conversation one time where maybe you don't wait quite as long on the second line therapy as the frontline therapy to start treating someone again. Do I remember correctly? And if that's true, is it for all patients, or is it the early relapsers, or?
So some of this, and I think and Scott alluded to this a little bit as well as Jay, would kind of depend on the time of relapse. So there are patients who, if you're asking, do I use the Guelph criteria to determine whether they should start next line treatment? Actually, I don't do it as much in the second line. And I think in patients who, as I mentioned earlier on, was that there are a percentage of patients that are probably cured with frontline therapy, although a small number. But if patients progress, especially if they progress in short order, I think that they're declaring that this disease is a little more troublesome, and I often will treat earlier. I think there is some evidence, especially with things like rituximab, that treating patients at lower bulk leads to higher CR rates. And so I generally don't wait till they get bulky and symptomatic in the relapse setting, again, with the hope that if the disease is being declared itself, I can change that natural history by intervening a little bit earlier.